Okay. We lost a little bit of time, but now we will start to summarize the scientific conference from yesterday, and I will find only a very few words for that. We have the organizers involved in that summary, so we will listen to three summaries from Dr. Margaret Kinner. She will start, and also from Gwen Gilliok. Both are from the Children's Hospital Harvard Medical School, and also from Professor Uwe Wolfrum, who is from the University Mainz, and I guess all of you know him very well. I will make that very short not to lose time, but I will mention you will have the possibility to ask one or two questions afterwards. Due to time, we cannot allow more. Please be so kind and prepare really clear questions which are of general interest. If you have questions more or less related to your personal situation, we kindly ask you to use the lunchtime, the breakfast, and all the breaks we will have during the day. Thank you very much, and here is the first scientific talk.
Is this on? Can you hear me? Thank you. My name's Marley Kinney. I'm a pediatric ear, nose, and throat doctor in Boston. And I get to do this, and I'm really privileged to be here, because we diagnose babies with hearing loss at birth. And so because of that, I've learned a lot about the causes of hearing loss in young children, and this is certainly one of them. But before I get going, I want to thank the planning committee. Gwen and I are the US version, but really it was the people here in Germany that did all the work, as everybody has said, and we really appreciate it. I also want to thank the interpreters. When we did this in Boston, we were still looking for interpreters an hour before the conference started, and I know how much work this is. All the different types of interpretation and translation and access. I know this is a lot of work, and I've been watching the interpreters and reading the written text, and they're really good. So anyway, thank you very much for that. And finally, and of course, without the patients and the families, there would be no reason for us to be here. I've been to many of the other family conferences. We're going to need a bigger room the next time we do this, so that's all good. So I'm going to just summarize very briefly some of the information that was presented the first day about the diagnostic part of Usher syndrome, and obviously, as many of the previous speakers have said, without a diagnosis, you wouldn't all know each other, and when we get to clinical trials or treatments, you won't know that you are eligible. So there's a whole bunch of reasons to do this. Many of the speakers on the first day include Dr. Kimberlin, who was part of the team that discovered the very first Usher gene, myosin 7A, and I'm assuming he's in here someplace. And then many of the other people that I listed here talked about different aspects of the genetics of Usher syndrome. Many other people talked about treatments or the way the different genes work together. So the truth is, this is really from everybody in the last 2 days. So Bill Kimberlin, as I just mentioned, really came up years ago with 7 steps to treatment for an inherited disease. And when he did this, we weren't very far down this pathway, and it was really starting with finding the genes that cause a particular disease. We're very far down that path in Usher syndrome, but there are other genes that we don't know about, and the way the genes work we're not completely sure about. But I think one of the things that's really key, and that Rebecca just alluded to, is get your genotype done if you can. Figure out what the gene is. Make sure you actually have, if that's the case, Usher syndrome. There are a lot of other things that cause hearing loss and vision impairment, and so having a correct diagnosis, whatever the diagnosis is, really matters. Everybody knows there are at least 3 types of Usher syndrome, but as Rebecca alluded to, some of the presentations are rather atypical for what we know from this little box up here. So it's entirely possible to have Usher syndrome type 1 and look like you have type 2, or have type 2 and have type 1, or have Usher syndrome 3 and look like type 1. So there's a lot to be learned based on the genotype, but also there's a wide variation of the way patients present. This is the reason to get tested. These are the known genes, but almost certainly there are either other genes that are also an underlying reason to have Usher syndrome, or genes that interact with these genes, and depending on how you play with the genes and what you do to the genes really may result in the clinical changes that we're all talking about and hoping for. So here's the other reason we need genetic syndrome. These are two of my patients. The one on the left, GJB2, that's connexin 26. This child presented as deaf. The patient on the right, myosin 7A, USH1B, presented as deaf. Same hearing test. And looking at a baby, when they presented, they look exactly the same. So for us to figure out what to do with them, we have to do genetic testing. This is a patient with myosin 7A, USH1B. This patient has a profound hearing loss. This is a patient with USH1B, myosin 7A. This patient does not have a profound hearing loss, at least not at the beginning. And so both of these patients have mutations in the same gene, but they didn't have the same mutations. And their clinical presentation wasn't the same. And actually the second patient here, this patient walked on time, her balance is pretty good. She wore hearing aids for years, and then her hearing loss progressed, and now she has cochlear implants. So same gene, different mutations, very important to figure this out. Bill Kimmerlane talked a lot about the history of genetic testing, and there are probably people in this room who got research testing. And if they only have one gene or they're not entirely sure, all these other things now that are available, common mutation testing came next, followed by single genes, followed by deafness panels where we have 120 or 30 or 60 genes, vision panels that are similar. What we probably need is a combined vision and hearing loss panel, so we're not missing anybody. And then now we're talking a lot about testing whole exomes, that's the protein part of the DNA, and then whole DNA testing. So things are progressing really rapidly, but each step has like the good news and the other news, and it's the other news that we have to be careful about. So why knowing? Why does this matter? And when you call the insurance company in the United States, they say exactly what our first speaker said. Why do you have to do this? How is it going to change? Why should we pay for it? Well, to get a diagnosis helps a lot, and then once there are interventions, that will also help. We also want to know how the genes interact, how they affect both hearing and vision and balance, and things that we're not really looking at very hard, but we should be. And some genes only affect the hearing or the vision, not both, or some mutations in the same gene. If you change this gene over here, it's like those little toys, you push this box and the other boxes move. Like what happens over here? So anything that we do to intervene, we have to make sure it doesn't make things worse. Are there genes we don't know about? Almost certainly there are genes we don't know about. And so, for example, USH2A, which is a really big gene and one of the common causes of Usher syndrome, there are a lot of different versions of USH2A. Which ones do you treat? Which ones do you worry about? How do they look clinically? So, and finally, do you actually have USH? And I know that sounds kind of silly, but there are people who do have vision impairment and hearing loss, but they don't have a clinical diagnosis of USH, and that would guide them down a different pathway. And that really gets to talking about what we consider Usher syndrome. It's a particular type of vision impairment, particular type of hearing loss, and then maybe other things. So what else can we learn from other people about if they study cilia, which are the little cells, the little hairs, they're not really hairs, but maybe there are other genes that have to do with cilia, microtubules. We actually heard from two other really excellent speakers in the last 2 days, Matt Tiska from Nashville, who talked about the gut. Well, how does that affect the ears or the vision? But the system in the gut that he's looking at is very reminiscent of what's going on with Usher syndrome. So maybe there's something that we can learn from that. And then Fred Schwaller from Berlin talked about the skin. Once again, lots of similarities. So there are other organ systems that we can learn from, and maybe they're even involved in Usher syndrome. So the other thing is better genetic testing. Anne-Françoise Roux talked about finding the second mutation or even the third mutation, and how that affects the diagnosis and then the interventions. Are there mutations in places in the DNA that we haven't looked, like in the introns, which is part of how the DNA gets transcribed, or in the splicing, which turns out different types of genes, or different versions of the gene. And is it really dominant or is it recessive? So are there two possible causes for the hearing loss and the vision impairment? That happens. I know that sounds rare, but it's not that rare once you begin to look. And then, of course, most important, and as everybody before me mentioned, We need registries. We need to be able to find the patients and families so that we can do better networking, although we're doing a pretty good job of that, and then better treatment as things come down the road. How will knowing the genes really help? Well, when are the genes expressed? They don't all start out at the beginning. What type of mutation is present? What kind of intervention is it going to be making the genes bigger, better, smaller, different, replacing them? Are there going to be medications? Yesterday there was a very eloquent speak on using something called baclofen, which is something we use for tight muscles, that maybe it will help with vision and hearing. So I think we don't know, but without knowing the genes and when the genes express themselves, we won't know what to do. And then when to treat. So say you assume you know the gene, and we know that when the genes are expressed at different times. So when do you do something about it? When do you do something about the hearing loss? When do you do something about the vision impairment? If it turns out there are GI symptoms, when do you do something about that? And we can test prenatally now for genes. So I have patients or parents coming to me and their baby is not born yet, and they know the baby is going to have something that affects their hearing or their vision. And they want to know what that's going to turn out like. And is there something they can do before the baby is born? So these are tricky questions, they're ethically tricky questions, and yet they're very exciting questions. And it's sort of what all of these people, the families and the patients and the science folks together are going to figure out. So anyway, thank you very much.
Thank you very much, Dr. Kena. We just decided to bundle the questions, so please write your questions, note them, and at the end of the free talks, you will have time to ask questions, and we know then how many time we have for that to be in time.